today to introduce my colleague from the BCCDC, Dr. Monika Naus, who is a public health physician with a career focus on communicable disease control. She's been at the BC Centre for Disease Control since July of 2001, where she is currently the medical director of immunization programs and vaccine preventable disease services and associate professor at the School of Population and Public Health here at the UBC. She's involved in a variety of provincial and national activities to improve immunization programs across Canada. She was a member of the National Advisory Committee on Immunizations for 12 years, including its chairwoman for 4 years. She's a fellow of the Royal College of Physicians and Surgeons in Public Health and Preventative Medicine and a fellow of the American College of Preventative Medicine. She's also going to be presenting today with Alex Nunn, who did her MPH here at the BCCD, or I always forget where I am, at UBC, then worked in immunizations at the BCCDC for a while and is now at PHSA and the lead of their influenza vaccination program. So welcome to both ladies. Monika's going to start and Alex will take over.
Thanks very much for that intro, Sarah, and thanks very much for coming, both online participants as well as real-life participants. So Alex and I have been asked to talk to you about the implementation of the healthcare worker policy, which is called the Influenza Prevention Policy in British Columbia. And we're just entering the 4th year of that policy at this point in time because we are relatively early on still in the influenza season, but vaccination clinics have started. And the reason why we chose to call this the Brave New World is the mandatory nature of this policy. Because in British Columbia, we don't have mandatory vaccination programs, but I did want to also take the opportunity to let you know that even in jurisdictions in this country where oftentimes the media particularly tend to consider them to have mandatory vaccination programs, for the most part, those are childhood vaccination programs where what's mandatory is documentation of immunization status or a valid exemption from immunization, which everywhere in Canada includes both philosophical exemptions as well as religious exemptions, as well as medical contraindications to vaccination. But for British Columbia, our childhood programs are completely voluntary, include the record collection process, and for healthcare workers, this was really the first mandatory immunization-related policy. Even though I think in the last few years, both Fraser and Vancouver Coastal have tightened up their assessment of immunization records for healthcare workers after several outbreaks of diseases like pertussis, measles, and mumps. So our objectives for today's session are to help you understand the key components of the influenza prevention policy in British Columbia, to describe the impact of the policy on influenza vaccine uptake in both acute care and long-term care facilities in British Columbia, and to show you some of the results of the evaluation of its implementation. And Alex has done the heavy lifting in that evaluation and is really a great person to talk to you about that. So again, the policy was introduced in the 12-13 season. And what the policy requires is that healthcare workers must either receive influenza vaccine or if they choose not to be vaccinated, that they don a surgical mask, not an N95 mask, so a surgical mask when in patient care areas of the facility. And this applies to all employees, whether they're unionized, whether they're excluded, as well as credentialed professions like physicians, residents who are medical trainees in the facility, volunteers, students, and contractors. And the first year of the policy was not enforced in terms of the kinds of activities that took place later on that Alex will describe. But during the second and third years of the policy, there was enforcement. And in the second year of the policy, visitors were added to individuals who must comply with the policy as well. And that resulted essentially in visitors to any healthcare facility in the province being eligible for publicly funded influenza vaccine. Practically, the policy is enforced between December 1st and March 31st. So during that period of time, if you're a healthcare worker working in a facility, that's when you either have to be vaccinated or wear a mask. And depending on the date that the influenza season starts. For instance, if we had an early influenza season, the provincial health officer, Dr. Perry Kendall, has the authority to declare an early start to the influenza season, or perhaps a late continuation of the influenza season. Influenza outbreak recommendations are unchanged during this time, and these are long-standing, and facility recommendations are that upon the recognition of an influenza outbreak, and that can be as little as a single case of laboratory confirmed influenza, there would be exclusion of unimmunized staff at the discretion of the medical health officer and the facility, recognizing that if there is a large proportion of unvaccinated staff who would have to be excluded, that could compromise staffing levels. But in any case, unvaccinated staff are advised to take antiviral agents during this time. And for residents of long-term care facilities, antivirals are also administered to both vaccinated and unvaccinated residents, because influenza vaccine does not offer as good protection against influenza in frail elderly individuals. So this policy came after many, many years of recommendations for healthcare workers to get immunized against influenza. And in the Canadian National Advisory Committee statement on influenza, there's a long-standing recommendation that I would say has certainly a moral imperative articulated quite clearly for healthcare workers with respect to their obligation to protect patients for whom they provide care through vaccination of themselves. And in many provinces, including British Columbia, influenza vaccine has been provided at no charge to healthcare workers for many years, beginning in Ontario, I know, in the late 80s, and in British Columbia, approximately that time as well. There have also been long-standing attempts during this time to improve coverage through voluntary means, like education sessions, promotion, lots of posters, and as well improving access to immunization services, things like mobile carts that make the rounds through the hospital or the long-term care facility, as well as other means. And one important change in British Columbia that's improved access to influenza vaccine is that since 2009, pharmacists are able to immunize. And last year, they immunized almost 1/3, or gave 1/3 of the doses that was administered throughout the province. There has also been a research, this CAP or CAB, knowledge, attitude, and behavior or practice studies conducted in healthcare workers. And I'll describe that on my next slide. In the 1990s, there were several randomized cluster studies that demonstrated the effectiveness of high rates of staff vaccination on resident outcomes in long-term care facilities. And these studies were largely done in the United Kingdom and in Scotland, and I think increased the level of interest among the public health community and the occupational health community, as well as those responsible for especially long-term care facilities, in improving uptake among those who provide care to residents of long-term care facilities. And then in this last decade, there was a move, especially in the United States, to mandatory schemes for healthcare workers. And that began even before the pandemic, the 2009 pandemic. And many of the facilities in the United States have mandatory schemes that do not allow for masking as an alternative to vaccination. So these are exclusively vaccinate or mask only in the instance where you have a medical contraindication to vaccine receipt. So, and that applies to a very, very small proportion of individuals who would have a valid contraindication to influenza vaccine. Largely, it's a prior episode of anaphylaxis, which is a severe allergy to the vaccine or a component of the vaccine. And these efforts have taken into account the recognition that influenza is a significant vaccine-preventable disease. And despite their imperfect effectiveness, influenza vaccines are a significant component of the immunization programs. In this province, about half of the doses of all vaccines that we distribute every year are influenza vaccines. and influenza, and that's about 1.5 million doses. And it accounts for about a quarter of our vaccine budget in the province. And the 2009 pandemic also, I think, raised the ante for healthcare worker immunization, recognizing that this type of event can occur. And as you know, there have been ongoing concerns about evolving strains of potentially transmissible influenza, especially the H5N1, and the possibility of a much more serious pandemic than we saw in 2009, and the importance of protecting healthcare workers in order to maintain our infrastructure for care delivery for ill patients. So knowledge, attitude, and behavior studies in healthcare workers, these have been done for, I would say, about 15 or so years. And during the pandemic, there was more interest in conducting these specific to the experience of the 2009 H1N1 pandemic. We did a survey here in British Columbia, and I see that George is here in the audience, to try to understand the drivers of healthcare worker decision making around getting vaccinated or not getting vaccinated during that episode. And most studies, and there was a meta-analysis of these studies published about 5 years ago, most studies have found that the key driver for healthcare worker immunization is personal, the sense that they are personally at risk of influenza infection. So that's interesting to me as a healthcare professional, that it's not primarily an altruistic motive to protect their patients, but it is around personal risk. Older healthcare workers are more likely to get vaccinated than younger healthcare workers. That could be a cohort effect, or it could be the occurrence of comorbid conditions at older ages. People, as they get older, are more likely to develop conditions that put them at greater personal risk of complications from influenza. And still, the existence of myths and misconceptions around influenza vaccine. And this one here is that influenza vaccine can give you influenza. The vaccines that we use in adults are not live vaccines, they're killed vaccines. And even though they are commonly associated with redness, pain, and swelling at the injection site, they can't actually give you influenza. You're not meant to be able to read this, but this is our very long list of eligibility criteria for influenza vaccine in this province. It's grown over time. We still managed to keep it to 1 page in our immunization manual, but it's just here to show you that almost everybody is eligible for free influenza vaccine through one means or another in the province right now, especially with that expansion to visitors to healthcare facilities. We had some creative influenza-seeking behavior among people who turned up at a health unit to get their vaccine, and by virtue of entering the health unit, they are now a visitor to a healthcare facility. So we've also expanded the program to children under 5 years of age, so kids aged 6 months to under 5 are eligible. Household contacts of individuals who are at high risk are also eligible, including household contacts of children under 2. So while we still have what's considered a high-risk program in the province, it has really grown over time. And it does differentiate us from some provinces in the country that have moved to universal vaccination against influenza. And that started back in the 2000-2001 season, with Ontario being the first province to introduce universal vaccination. And I think it's still a little bit controversial about whether that's a good use of resources, but certainly at the frontline level in delivering vaccines, it doesn't require you to run through this long list of eligibility criteria. And as I said, virtually everybody is eligible at this point in time through one criterion or another. We have a long-standing process in British Columbia of assessing healthcare worker uptake in acute care facilities and long-term care facilities. And while the methods have changed, and in the last several years, we're assessing uptake using the occupational health database called WHITE, which all regions participate in now. I think that over time, these have given us information about what healthcare worker uptake in the province has been. And I think the important things that I want to highlight for you on this slide and this is for acute care facility healthcare workers, is that we had, I guess, stagnant and you could even say declining vaccine uptake rates among acute care facility healthcare workers prior to the implementation of this policy. So rates really in the low 40s throughout that period of time. During the pandemic season, the uptake of pandemic vaccine was higher than of seasonal vaccine. Both vaccines were offered that year, and there was quite a bit of confusion about what the recommendations actually were. But I think that after the pandemic year, we actually saw, if anything, a blunting of influenza vaccine uptake. And starting the first year of the influenza prevention policy, which is the vaccinate or mask policy, I think you'll agree that there was a remarkable increase in vaccine uptake. And that gain was really in the first year of the policy. And subsequent to that, there have been slight increases, but I think generally a plateauing of the levels. So not a lot of change since that first year of the policy. So the 3 years, the 3 recent years, which are the policy years, are all years during which white data has been used for the analysis. Some segments of the workforce are not included in the white data, so physicians prominently have not been incorporated into that, but it does include a majority of healthcare workers in the province, and all facilities report through this process. These are the results at the regional level. So I've given you the 8-9 season as a comparison because that was the last year before the pandemic season. And you can see that overall the provincial rates were 42%, with some variation by health authority, and the lowest uptake rates in Fraser Health with 33%. Interestingly, it was the Chief Medical Officer in Fraser Health who I think was the key engine in getting this policy in place at a provincial level in British Columbia. And significant increases in uptake in all of those health authorities. Interestingly enough, the highest uptake in Fraser Health. So that's the region that started off with the lowest prior to the implementation of this policy. And overall at the provincial level, a 34% increase if you look at this past season compared to the year prior to the policy implementation. This is a scatter plot of the facilities, acute care facilities in the province. And across the x-axis is the size of the facility with respect to number of staff. And on the y-axis is the percent vaccinated. And apart from a few stragglers with lower uptake rates, you can see that for the most part they're above 60% and scattered around that provincial average, including very large facilities. So there doesn't seem to be a relationship between facility size, particularly, and uptake rates. In long-term care facilities, a similar kind of picture is seen, but the differences here are that uptake rates were higher prior to the implementation of the policy, so that the 8-9 year was at a provincial level, the uptake rates were 64% in residential care, and I don't think that they were showing any signs of an increase. And in fact, during the pandemic season, and we didn't assess pandemic vaccine uptake, only seasonal vaccine uptake in long-term care, they really plunged in long-term care facilities, and there were some small increases in the 2 subsequent seasons, but not to the level where the rates had been prior to the occurrence of the pandemic. And in the 3 years following the policy implementation, those rates have increased to approximately the rates in acute care, but a little bit lower. So, which is surprising actually, because historically the thinking had always been that healthcare workers who work in long-term care facilities have a more type of family or household relationship with the patients in those facilities, and that they are far more likely to get vaccinated because of that. And you can see that at the regional health authority level, there was sizable variation prior to implementation of the policy, with the lowest rate of 49% in Northern Health, And there have been increases across the board in all of the regional health authorities, and overall a 13% increase. So a smaller percent increase, but they were starting from a higher point. And this is a scatter plot of the long-term care facilities in the province by the same parameters, facility size and coverage rates among healthcare workers. You can see that there are a number of facilities with 100% coverage rates. Keep in mind that this is all self-reported influenza vaccine receipts, so that's a very different standard than we use for childhood immunization assessment, which requires a record with a day, month, and year of receipt of a vaccine. But a wider, I would say, just a wider distribution of influenza vaccine uptake, but also larger facilities able to achieve high vaccine uptake. There are a number of activities that have been proceeding during this time to look at the evaluation of the policy, and one important thing is that British Columbia is the first province in the country to have launched a policy like this. So there's been a lot of interest in our experience, and one of those activities was an influenza research symposium to which experts in influenza were invited to help advise British Columbia on the appropriate methods to try and use to evaluate the policy. There have been a number of studies done of using mixed methods, qualitative and quantitative, to determine or examine the success of the implementation of the policy, and Alex will speak to you about that. And there are studies that are ongoing to address the impact of the policy on nosocomial infections in acute care hospitals, absenteeism among staff, and long-term care facility outbreaks. Also in the new year, we hope to conduct a healthcare worker knowledge, attitudes, and practice survey. And with that, I'd like to turn it over to Alex to take you through the mixed methods evaluation of the policy.
All right, thanks, Monika. So I've been involved in the policy evaluation for a bit over a year now, and there have been numerous phases of the policy implementation, and as Monika said, we've used a number of different methods to look at policy implementation. So I'm going to tell you about two of the studies that have happened. I'll give you the results of those, and one of them, the first one, is a qualitative case study that was conducted the first year of the policy, so that's 2012-2013, and that was the year that the policy was introduced, but the disciplinary measures were in abeyance in that first year. And then the second one that I'll tell you about was a survey, a mostly quantitative survey of healthcare facilities. And so we were looking at implementation at the facility level. So the first one is sort of implementation at the leadership level, and the second's at the facility level. So here we go. The case study examination was conducted by Charmaine McPherson and Donna McDougall, and they're both at St. FX University. And they're involved on a lot of national flu research projects. So they did this case study and chose the case study methodology. Oh, sorry. Yeah, the study purpose is to better understand the key facilitators and barriers involved in developing and implementing a province-wide condition of service healthcare worker flu policy. And they chose the case study approach because case studies are great to use when the issue is highly contextual in nature, as it certainly was in BC, and when there are many types of data and variables that you might be interested in looking at. So the policy implementation is a unique case, and they developed a few theoretical propositions from existing literature and best practices, and that they used those propositions to guide them through the analysis of focus group transcripts. So they had 7 policy implementation teams participate in focus groups, and those were implementation teams from the regional health authorities and at the provincial level. So they came up with these four themes, and all of the themes are kind of overlap. So I'll just start talking about practice paradigms. So what they found from the interviews was that the province-wide approach with lots of senior leadership engagement was really beneficial in terms of bringing in this policy, and that it really helped in places where they had dedicated resources to bringing in the policy and all of the procedural changes that came along with it. So it helped to have project management and financial resources allocated for it. They also noted that there were lots of emerging partnerships that had to happen across the sectors, and there were highly collaborative planning processes, bringing all people from all the different health authorities together to talk about how to introduce this policy consistently at all the different organizations. But the one big challenge really was sort of marrying public health and population health values within the context of acute and long-term care facilities and the processes that they have. And so this is an example of a quote, and there were many quotes like this. There was this kind of tinkering from public health to say, you might want to think about this and you should do this when you're implementing the policy. And an acute care person says, have you ever run a hospital? No. You don't know how to run clinical operations within agencies. And so sort of imposing this policy at the provincial level was great, and then it was just hard to actually make it happen at the level of a hospital or a long-term care facility when they're sort of prioritizing different things. So there were a number of policy implementation gaps identified. These are affectionately called by the two researchers PIGs. So the PIGs included, so a policy implementation gap really means the difference between what is intended to happen and what actually happens. But one thing that was really helpful was having this clear overarching policy and also a great foundation to build on, because all of the health authorities already had really comprehensive influenza vaccination programs, and so they were just sort of scaling those up. But the gaps were in terms of making it consistent across health authorities. And once the policy came into place, there were all of a sudden all of these other things that needed to be defined, and including, for example, what is a patient care area? Because any unimmunized staff member has to wear a mask in a patient care area, and so then everyone was kind of trying to figure out how to define all of these policy components at their health authority. So they also identified pathways of power. So there were different groups that had power in terms of this implementation process. The provincial mandate was great in terms of sort of power because it gave the policy credibility and clout, and also influenced a high degree of collaboration. But the government was, or the ministry was seen to have sort of an extra hand in the power because they announced the policy in August before it was due to start in December of 2012. And a lot of the operational people felt that that maybe didn't give them enough time to get organized. And then the ministry actually made a unilateral decision the day before the policy was due to start in the first year, to put the disciplinary measures in abeyance and to have that first year be sort of a learning year for everybody. In terms of unions were also seen to have quite a bit of power. They were going through collective bargaining at the time, and they ended up being opposed to the policy and filing a grievance, which went to arbitration by the beginning of the second year of the policy. And physicians were also seen to have quite a bit of power they were engaged in a power play around the policy, and they were pushing back and we'll talk a little more about that. Another thing that came out was there was a lot of sort of punitive and combat discourse in the first year of the policy and in people's responses about it. So we talk about enforcement. People used this term battles. They were winning and losing in different sides and fighting, which is kind of unfortunate. And we've really, in terms of all of the policy communications, a lot of the language has been softened a lot. One thing in the first year of the policy that they used were stickers on people's ID badges to indicate that they had been vaccinated, and that was sort of one of the major contentious issues for the unions, and the stickers were removed by the second year of the policy. And lastly, the change right sort of at the end of the preparation season, everyone had been preparing, and then the disciplinary measures went into abeyance, and that personally impacted some of the people who were involved in the implementation, and they sort of felt that they were blindsided or demoralized by that decision just at the last minute. And then there were people who sort of questioned the ethics of the policy implementation process, and some respectful workplace issues. In the second quote that you can see there, it became a challenge when other people had to enforce, sort of were meant to enforce each other's mask wearing. All to say, it, as you saw in the stats, there was a huge increase in vaccination in that very first year, despite all of these challenges with implementing the policy that first year. But a few recommendations that came out of the focus groups were how important it is to deliberately allot time to plan appropriately, to consider the complexity of political contexts. So specifically, this is talking about the fact that the unions were in collective bargaining, and that could have probably, like, talking to union groups and physician groups earlier in the process might have been helpful. And to develop sound enforcement plans, which certainly has been done since this time, and to provide education and skills to frontline providers so educating providers about the policy and about the vaccine so that they know how to address questions. And so maybe I'll just pause here and ask if anyone has any questions so far. Yes. Oh, okay. Oh, sorry, I'm breaking tradition here.
All right. Thanks. Great presentation so far, Alex. I have a quick question for you. Based on what you've been sharing with us, it seems like there was no value opposition to the actual policy in itself, but rather how the policy was actually delivered and or organized. I don't know if you can provide any insight on exactly if there's any further insight into why exactly that was, because from what I understand, there were two grievances, one from the BC Nurses Union and one from the Health Sciences Association, which was the collective body representing all healthcare workers, and they didn't drop their grievance.
So the grievance did go to arbitration, and in the arbitration in 2013, the decision was that it was reasonable, the policy was reasonable and within the employer's rights. So that's why we still have the policy. I think that ultimately it's just such a tricky thing to coordinate, and we're the first province to have done a policy implementation like this, and so it's been a big learning experience, and luckily all of this research about the implementation process is able to be shared with other jurisdictions who are considering implementing a policy. And yeah, a lot of the process issues are kind of a big deal when it comes to unions and grievances. And we can talk a little more about this, but just you've probably heard, or maybe not, but in Ontario there was a grievance that went to arbitration, and in September there was a decision for the Sioux area hospital that the policy was not reasonable and not within the employer's rights to implement. And that was largely due to process issues. So they were using stickers and identification that sort of went against the privacy. It was a privacy issue. And they also had a very explicit goal in Ontario of increasing vaccination to 95%. And that was sort of their main goal of the policy. And because of that, it was determined to be coercive. Whereas in BC, increasing immunization, of course, is one of the main goals, but our ultimate goal is patient safety. And we allow, we encourage mask wearing as an acceptable alternative to vaccination. So yeah, it gets sort of tricky in terms of when we're talking about coercion and what's mandatory. And I think all of that stuff gets people's backs up against policies like this when everyone pretty much agrees that immunization is a good thing. So that answers your question. So we'll go on to the facility survey, which was a survey of directors and managers of healthcare facilities to find out at the ground level what was the process of implementing the policy, trying to understand the logistics, supports, and challenges. So stakeholders and the Provincial group worked on this online survey that was sent around to 263 facilities from 3 of the 5 regional health authorities. 2 decided not to participate due to timing. And so with the data, there was a whole bunch of different types of data that came back from the survey. So I'm going to show you some descriptive statistics, a bit of qualitative analysis was done, and also a multivariable linear regression looking at factors that were associated with higher immunization rates, controlling for the facility's previous immunization rate. So 132 facilities responded, and this group of respondents are kind of interesting because they all of those facilities had, or the group had significantly lower vaccination coverage than the non-responders. So that's something to keep in mind in terms of the results. So 89% of the respondents said that their facilities successfully implemented the policy. And when they talked about success, they talked about staff complying and staff being cooperative and having high immunization rates, particularly among direct care staff. It was a little different for people who sit in offices and don't have direct care. But only 52% of the respondents found the policy easy to implement at their facility. And so challenges included just staff being resistant to being vaccinated or masking, and also challenges with the logistics of actually enforcing that mask wearing for unimmunized staff. So not quite sure what the definition of easy is. It was a lot of work by people at all levels throughout the organization, but in particular, there was considerable added workload for every manager because the responsibility falls to direct supervisors to monitor mask wearing for unimmunized staff. So in terms of logistics, the top 3 most successful methods for delivering the vaccine to staff were on-site clinics, peer immunization, which means basically nurses being trained to just give flu shots whenever their colleagues are sort of available and around. So that can happen in the evenings and weekends when vaccine clinics might not be offered by the health authority. And also bringing vaccines to the workplace. So that's mobile carts, like Monika mentioned before. And peer immunization, it turns out, was the only factor that was significantly associated with higher facility level immunization rates. So associated with 7.5% higher immunization rates. In terms of mask wearing, most facilities made sure that masks were available in their patient care areas, and they monitored staff mask wearing posted reminders, provided education about masks, and encouraged peer support and monitoring. And I think there could be improvement in providing education to unvaccinated healthcare workers about masks, because I think if more people understood why they were wearing masks, they might be more inclined to do so. And in terms of supports, management staff were known to be very supportive of the policy, and also nursing staff, but not all physicians supported the campaign, and also not all physicians were monitored in terms of their mask wearing. And so some people felt that a double standard was being set where physicians weren't necessarily complying as closely with the policy as other healthcare workers. And physicians have a powerful voice, so their ambivalence served to generate confusion. So the top, generally, none of the facilities had any trouble with providing vaccine to staff, but what was challenging was enforcing the mask wearing. And a good majority of healthcare facilities had trouble, managers had trouble monitoring mask adherence, just in terms of time and other things, we'll get to that. And unvaccinated staff were just not wearing masks, and they were having difficulties identifying who was unvaccinated. So every manager was supposed to receive reports about who was vaccinated and who wasn't, so that they'd have a list of people to follow up with who weren't vaccinated, who should be wearing masks in patient care areas. But 43% of acute facilities, only 43% of acute facilities had accurate reports. So that made it challenging for the managers to actually go and find the people who should be wearing masks. And long-term care facilities had an easier time of this. And as you saw in the scatter plot, many of the long-term care facilities are smaller, so that might be part of it. And generally, there was some inconsistency in terms of enforcement. So 57% of acute facilities always enforced mask wearing, whereas and 77% of long-term care facilities always enforced mask wearing. So in terms of the recommendations from this study, we recommended that managers need to be well supported. We need to recognize that this policy does increase their workload. It adds another thing that they need to do each week to check their reports and go and check up on people. And we need to gain support from physician and nurse leaders who may not be as outwardly supportive of the policy as we might like, and provide training on enforcement. And so we've been doing that, and there are guidelines for how to enforce the policy, and a new checklist this year that's going to managers about sort of what you need to do for flu season, how you need to inform your employees of what their responsibilities are under the policy. And we also recommended improving consistency. So there were inconsistencies in enforcement in a couple of different ways between facilities and different facilities. You know, a healthcare worker working at one facility would need to, or working at two facilities, would need to sort of see that it was being enforced the same way at both facilities. And between managers, sometimes one manager is spending more time doing this than another. And we also needed to establish an accurate process for identifying healthcare worker immunization status, and that's happened this year. I'll tell you more about that in a second. And then consider that peer immunization seemed to be a really great strategy for further increasing vaccine accessibility. So all of these results were presented to the Provincial Coordinating Committee for the policy, and they put out 3 recommendations for this year: that frontline managers continue to be educated and supported, to ensure that mask wearing is appropriate and consistent, to develop a consistent database for entry of physician vaccination status and to monitor and enforce physician compliance. And this has happened as well. So now all physicians can self-report their vaccine or their decision to decline the vaccine and wear a mask in patient care areas. And to develop a communication strategy that addresses vaccine mismatch, among other issues. So new this year, we have more supportive tools for managers. The physicians in all of the lower mainland health authorities report to the same system, their vaccination status, and all employees now across all health authorities in BC also self-report their immunization status to the same system, which is really great. That last year there were problems with all of the health authorities having different systems that didn't interact with each other, and so this year should be a lot smoother. And all staff are required to self-report this year. So last year it used to be that only if you got a flu shot would you go and report that you got vaccinated. But this year, now we're asking all staff to report so they can say that they either got vaccinated or they've declined vaccination and are going to wear a mask. And that will really help us in terms of getting more data about who's complying with the policy. And it also helps managers to figure out who they need to follow up with for what reason. And with that Ontario arbitration decision, there's renewed interest from the unions, from the BC Nurses Union in particular, in trying to get the health authorities to withdraw the policy. So they are probably going to be active in doing that again this season. And so I'm showing you the self-reporting page here that all health authority staff go to, as well as all medical staff. And so our conclusion is that the policy has had a hugely significant impact on influenza vaccination uptake. And the increase happened in that first year of the policy, despite some of the challenges with implementation of the policy that year. And the evaluation has identified areas for improvement and also identified a lot of really positive things that have come out of the implementation process, including all of the collaboration among health authorities and all of the successes at facilities that have really high immunization uptake and have staff who really care about protecting their patients from influenza. And we have still ongoing evaluation activities, so there's more implementation evaluation stuff going on, but we also have a few studies that Monika's involved with, well, Monika's leading, about the impact of the policy in terms of nosocomial influenza, absenteeism, and outbreaks in long-term care facilities. So we have lots of people to acknowledge who have been involved in all of these evaluation activities. And I gave you here some spots that you can go for more information. One really great document, if you want to look at it, is the BCCDC's discussion of the evidence to support the policy. And so you can find that by actually just Googling BCCDC discussion of the evidence. It'll be one of the first things that comes up. And the ministry has put out a whole bunch of frequently asked questions documents that are available at this PHSA site, but all of the health authorities post them on their own pages as well. And if you ever have any questions, you can email me at flu@phsa.ca. So thanks, and we're open for questions.
Thank you for the talk. I have sort of a two-part question. In BC, of the healthcare workers who are not immunized, approximately what proportion have medical contraindications and what proportion just choose not to? And of those who choose not to, do you know why they're choosing not to?
It's a great question. Thank you very much. So fewer than 1% of individuals should have a contraindication to influenza vaccine, substantially fewer, because the valid contraindications or medical contraindications would be a serious allergic event diagnosed as anaphylaxis to a previous dose or to a component of the vaccine. And one important thing that's happened, actually stimulated by the 2009 pandemic, is more research into whether allergy to eggs or egg proteins is a valid contraindication to influenza vaccine. Because all of our influenza vaccines are manufactured right now in eggs. And there's been a lot of studies and a compilation of data that demonstrate that individuals with egg allergies can be safely vaccinated against influenza. And so there has been a rolling back and significant changes to that specific contraindication. But there are the other components in the vaccine as well. So it's substantially fewer than 1%. So the vast majority of individuals who aren't being vaccinated are choosing not to be vaccinated. And some of it is, we're going to find out specifically in British Columbia when we proceed with our survey of healthcare workers. That's been in abeyance a few years in a row as well, but I think we're hoping to do it at the tail end of the current season, so in the early winter, or well, late winter, I guess, early spring, and that should give us some more specific information about why people are choosing, whether it's an objection to the policy or whether they still have outstanding concerns about the potential benefits or safety of the vaccine.
Hi, thank you. You mentioned that some of the exceptions for vaccinations would be made for, say, religious or other reasons. To what extent does the vaccination policy change in response to the virulence or pathogenicity of a specific viral threat? And do you think that that might contribute to a perception that the policy is perhaps inconsistent?
Are you talking about the vaccine effectiveness for last season?
No, I'm sorry. I understood that this policy is, while you're talking specifically about influenza, if there was another disease, a viral disease, that was, say, more dangerous than influenza, would the policy on that one still include exceptions for personal reasons? Or would, say, in the case of a more dangerous disease, would those simply not apply?
I think the classical, like in the US, I think, most of the facilities that have influenza policies do not allow religious exemptions. The exemptions really are around medical contraindications to vaccination. And, I mean, there aren't that many religious prohibitions to influenza vaccination. Is anybody here aware of a specific religion that prohibits influenza vaccination? So I think it's, these kinds of exemptions, religious exemptions, are really to take into account faith-based groups like the Netherlands Reformed, for instance. We've got communities in British Columbia that don't vaccinate, and some of those individuals are healthcare workers. But some of those individuals choose to vaccinate themselves, even though they may be from a faith-based group that doesn't generally vaccinate. I don't know whether I've answered your question, but I guess if you're asking, would there be a stronger mandate if there was an Ebola outbreak in... vaccination as opposed to allowing you to mask? Perhaps. I mean, that's a brave new world as well. It would be interesting to understand what the approach of healthcare workers would be, and I think it depends a lot on the vaccine. If you had a highly effective vaccine that could prevent a potentially fatal disease, I would think so. We were discussing this actually recently about whether there's ever been a case of an individual refusing rabies post-exposure prophylaxis. After a bat bite, has a parent ever declined to have their child receive rabies immunoglobulin and rabies vaccine, knowing that rabies is a fatal disease? And I think you're probably right that the more fear that's associated with an adverse outcome, the more likely a person is to be vaccinated.
Can I ask a quick follow-up question to that? And I see more hands around the room. If we were to have another H1N1 pandemic this year, would this policy cover that pandemic? Would it require that everybody also be vaccinated against H1N1? Or does this policy simply cover the seasonal flu?
The policy as currently written is designed for seasonal influenza, including the timing. The December 1st to March 31st, that's sort of a classical seasonal influenza. Pandemics tend to be outside of the typical season. But I can't tell you whether there would be a decision to develop a similar or analogous policy if we had a pandemic threat. That's a good question to ask Perry Kendall and others.
Thanks, you guys. I'm interested, I came late, so I may have missed it, whether the workers' compensation system or WorkSafe BC is a player in any of this in terms of the workforce being in an environment where they are exposed to a hazard, and this policy has a role to play in reducing exposure or hazards. I'm just curious whether they have had involvement in any of this, or you could see a role for them in terms of trying to improve the implementation of the policy, or is it just outside of the scope of all of that?
I was engaged with them a few years ago during our measles outbreak, because we had a big measles outbreak in 2010. We had a big one in 2014 as well, but the 2010 one was remarkable in that there were a lot of healthcare worker exposures in places like children's hospitals. Healthcare workers who were undocumented with respect to their immunization status. And we did have some follow-up calls at the time with WorkSafe to find out, what involvement they saw for themselves in terms of strengthening the existing policies in British Columbia for healthcare workers. But I'm not aware that they were involved in the influenza one. And Alex, who's been sort of more than knee-deep in flu for the last year or so, you...
No, I really don't know. Sorry.
Don't know. George.
Hi there. Thanks very much for this. I was wondering, you certainly noted that physicians were not sort of directly, how should I put it,
Helpful.
required.
They weren't very helpful.
But I'm curious also about the other huge component of the healthcare workforce, the contracted workers, who aren't employees of the health authorities directly. How do they fit into this? Is there a thought to move towards making this a condition of the contract itself to have their employees vaccinated, especially since if you consider cleaning, security, food services, the potential for I certainly understand that the main driver here is patient safety, but there's no doubt that those three groups come into close or reasonably close contact with patients as well, and would present a risk for transmission.
Yeah, for sure. So contractors and vendors, they are all covered by the policy. They're individuals covered under the policy and are expected to comply. However, the health authorities and sort of the provincial leaders of the policy don't have really any formal way right now to ensure that happens. Right now, contractors are required under the policy to report their immunization status to their supervisor. And we don't have a whole lot of information about how often that happens or what the supervisors do with that information. So that is certainly a tricky part about ensuring compliance. And same goes for visitors, really. Visitors are covered by the policy as well, but there's no one particularly assigned to ensuring that everyone who walks into a hospital has a flu shot. So yeah, it would be interesting to get further into that.
So when you say that they have to report to their supervisors, you're talking about the contract supervisors.
They're contract supervisors.
So they don't necessarily inform anyone in any position of authority within the hospital or in their unit. So
No.
that is quite a considerable cap.
Mm-hmm, mm-hmm.
Just one very quick comment, sorry. Just from some work that we had done far in the past, I was interested to note that you said that the peer immunization component there that seemed to work well. We observed also that the people who had the highest success at persuading their colleagues to immunize were people with public health backgrounds, because they could actually, they not only had the relationship, the association, but they also had the opportunity to respond to the questions around risks and concerns that mattered to healthcare workers. So it was not just sort of being from the same team, but also having that knowledge base.
That's really interesting. Thank you.
Okay, I'm sorry, folks. We are over time. I'm sure you can go up and ask questions of Monika and Alex afterwards. It's a good lesson in getting your hands up early in the question period, because I do it on a first come, first served basis. So thank you very much to our speakers for today.